Okay, good morning and good afternoon, everyone. Thank you all for joining this HemoCue webinar. The session today is being presented in partnership with AmSECT. So first, I'd like to give a special thank you to Blake, Kelly, and everyone at the AmSECT team for their support in making this happen today. A couple quick housekeeping items before we start. We'll be holding a live Q&A session at the end of the presentation, so please feel free to submit your questions through the Q&A box at any time during the talk, and we'll do our best to get through as many as possible at the end of the session. My name is Adam Dorsweiler. I work with HemoCue as a marketing manager for the Americas, and I'm excited to be here with you today. Our session today will take a deep dive into the impact of hemolysis, comparing test methods, and discussing how these concepts can be applied in a real-world setting. So with that being said, it's my honor to introduce our speaker for today, Dr. Tim Maul. Dr. Maul brings a unique perspective to this topic, as he's both a senior research scientist and a certified clinical perfusionist at Nemours Children's Hospital in Orlando, Florida. He earned his PhD in bioengineering from the University of Pittsburgh, where his postdoctoral fellowship and early faculty career focused on preclinical development of mechanical circulatory support devices, with a focus on biocompatibility through in vitro and in vivo hemolysis and thrombogenicity testing. Throughout his career, Dr. Maul has been at the forefront of ECMO and VAD development and clinical utilization. He served as an ECMO coordinator, a key member of the ELSO simulation team, and is the current ELSO Technology and Innovation Chair. Dr. Maul currently holds faculty appointments at both the University of Central Florida College of Medicine and the University of Pittsburgh Department of Bioengineering. With dozens of peer-reviewed publications and a career dedicated to pediatric cardiac surgery and medical device innovation, he's well positioned to lead today's discussion on insights into modern hemolysis assessment. So Tim, thank you for being here. I'll hand it over to you.
Thanks for the invitation. Without taking too much time, we'll get started. So the things I want to talk about with everyone today is why we care about hemolysis, what we think about the current methods for detecting hemolysis and where some of the gaps with laboratory testing are. And I'm going to specifically focus a lot on utilization of hemolysis testing in the setting of cell salvage quality control. And so the professional standards that we're trying to align with for doing that testing. And then some of the takeaways that we've had from our program in utilizing the quality control program that we've put in place. So just as a basic definition, hemolysis is just the rupture or breakage of red cells causing the release of hemoglobin and their other internal cellular components into the surrounding fluid. And the reason that we care about hemolysis is that it promotes an inflammatory response to the activation of macrophages. The hemoglobin molecule is a promiscuous scavenger of oxygen-containing molecules, including nitric oxide. So at the local tissue level, if you lose nitric oxide to the hemoglobin molecule, then it can cause blood vessel constriction because nitric oxide is one of the molecules that helps your smooth muscle cells relax. Nitric oxide is also known to make platelets quiescent. So if you lose your nitric oxide, you can start to create localized platelet activation that can convert into promoting thrombosis. So if you couple those two scavenging properties together, then they will promote a consumptive coagulopathy and increase in risk for local tissue occlusion or strokes. On the kidneys, free hemoglobin can cause nephropathies that result in renal failure and the need for CRRT. And again, the more organ systems that you involve or cause localized tissue ischemia, the more organs that will begin to fail and the worse the outcomes for patients tend to be. It's been interesting that there was actually some studies that showed that if you actually injected healthy human volunteers with free hemoglobin, you could actually get patients that would experience pain, increased blood pressure, dysphagia, or evidence of hemoglobinuria with levels between 0.2 to 0.6 grams per deciliter of free hemoglobin in their blood. So basically what I'm saying is that hemolysis is not a good thing. And so we want to be able to detect it and try to mitigate it throughout our interactions with patients and the technology that we use within the hospital setting. Now, hemolysis can originate from medical conditions like sepsis, But what we're going to focus today on is related to transfusion or storage lesions because of the cell salvage component of this talk. But any patient that's presenting with any sort of disease state related to infections or inflammatory processes, uh, their red cells actually become more fragile as a result of these processes. So when that blood interacts with the cell saver or any other medical device that contacts the blood, those cells are more fragile and more likely to lyse as a result of that interaction. When we utilize things like suckers for cell savers or cardiopulmonary bypass or any other devices that interact with the blood, we need to be aware of the mechanical hemolysis that can occur. And since the development of all of the pumps that we have for medical devices, particularly ventricular assist devices, we've been studying the mechanical conditions that cause red cells to become damaged. One researcher back in the 70s combined the results of a series of published studies to develop a Leverett curve for red blood cells, platelets, and white cells. And so what you can see when you combine all of the various animal, in vitro, and in vivo data is that there's these isolines for each of the cell types with red cells, platelets, or white blood cells, where you plot the shear stress that the cells are exposed to against the time of exposure. So anything to the right of any of these lines, the cells will be basically ruptured or damaged because of the shear stresses. And anything to the left of the lines means that the surface effects, things like surface chemistries or surface roughness, will be the thing that would potentially cause the cells to rupture. So basically, we do not want to live on this side of the curve when we're interacting with patient blood. And one of the interesting things that happens is that an air-blood interface, which can happen in things like cardiopulmonary bypass or cell salvage systems, will actually shift this curve to the left, meaning that less shear stress for less time exposure can create the same level of hemolysis that a high shear stress for a short time exposure would engender. And there was also an interesting study in 2000 from Mulholland et al. That showed that when you actually applied a negative pressure to a cardiotomy reservoir, either for bypass or for cell saver, that there basically becomes a threshold after which you get this linear increase in the rate of free hemoglobin release in the cells that are exposed to that system. So starting at about negative 120 millimeters of mercury, you get this nice linear increase in hemolysis that's occurring because of the mechanical damaging effects of the vacuum that's been applied to the system. So this is one of the reasons why when we choose cannulas, we set our vacuum sources for cell salvage, that we try to keep negative pressures under or no more negative than about 100 millimeters of mercury in our systems. So we worry about hemolysis and the way that we're interacting with the patient's blood, but we need a way to basically determine have we caused hemolysis or how much hemolysis has occurred as a result of our interaction with the blood. And there are several direct methods for determining whether plasma-free hemoglobin exists within the blood. These are the cyan-met hemoglobin assay, the TMB peroxide reaction assay, an ELISA type assay, or a spectrophotometric assay. The other methods that can be done are what we consider indirect methods. And these are like your LDH, your haptoglobin depletions, the hemoglobin urea test results. So if you see, red in the urine, or testing the patient's bilirubin. One of the most important things to note about most of our direct methods is that these are all pretty much laboratory developed assays. There is no FDA approved process for detecting hemolysis other than using the HemoCue's plasma low hemoglobin system for quantitative assessment of free hemoglobin, specifically in the setting of stored blood or stored plasma. So when we look at the methods that that we've outlined as direct or indirect, they all have some pros and cons associated with them. So the TMB, or the tetramethylbenzidine, is one of the most popular ones because it is available as a commercial kit, even though it is a laboratory developed assay. Um, and it contains a non-carcinogenic substitute for the traditional benzidine chemical that was originally developed for it. Uh, People for a long time had strayed away from TMB because it had a carcinogenic reagent, but now they've gone back to it with these commercially available kits with the less carcinogenic tetramethylbenzidine assay reagent within the kit. It is a chromogenic kit, so the more free hemoglobin that's in the plasma sample, the darker the color of the assay will be. And so you can basically have a quantitative analysis of the free hemoglobin within that plasma assay. It can be somewhat time consuming, and you do have some inter-run variability. So tests that are run in different days, can have slightly different results. And a lot of laboratories will batch their initial calibrations and assays to, once a day or something like that to try to eliminate this inter-run variability. So it can lead to limited availability of the results for patients within a specific time frame within the institutional lab setting. The cyan-met hemoglobin method is an internationally recognized method for detecting free hemoglobin. And it uses Draedken's solution, which is basically potassium cyanide or potassium ferrocyanide, to stabilize free hemoglobin into the cyan-met hemoglobin molecule. And then you can quantify that particular molecule with spectrophotometer at 500 nanometers of wavelength. So basically, you're measuring how brown a solution has become with a specific wavelength on a spectrophotometer. Despite it being a standard solution to create the cyan-met hemoglobin molecule, it's still considered a laboratory-developed assay subject to the CLIA guidelines. ELISAs, or enzyme-linked immunoabsorbant assays, use a fairly complex process of antibody binding to specific molecules in solution. So there are antibodies to human plasma or human hemoglobin. And these antibodies then are tagged with either a chromogenic or a fluorogenic molecule that can be detected in a spectrophotometer or fluorometer. Again, these are quantitative assays, but are still considered LDAs subject to the CLIA guidelines. Photometric type assays include the CRIPS and the Harbo methods, where plasma is separated from the blood and analyzed at multiple wavelengths on a spectrophotometer. And the reason that they use multiple wavelengths is that there are interfering substances within the plasma. And so by doing the analysis at two different wavelengths, you sort of isolate the effects of some of these interfering substances. The measurements are compared to known concentrations of hemoglobin in solution, and then you basically develop a quantitative linear curve related to the absorbances per the calculations for CRIPS and Harbo. This can be done with a standard standalone spectrophotometer. That's what we did in our research lab for all of our preclinical animal testing. But you can also use a commercial HemoCue device, which is basically, an easy single assay, put a drop of blood into the cartridge, put it into the system, and then it reports out the free hemoglobin result for you and it does all the calculations within the system. And so that's the method that we've adopted at our hospital for our cell salvage quality control system, is the HemoCue one. When we look at the indirect hemolysis detection methods, LDH has been a popular one, especially for outpatient bad patients, because it's a readily available chromogenic test in most clinical labs. I mean, almost everybody looks at LDH in the clinical setting, especially in intensive care. But it's relatively nonspecific. So in acute settings or in surgical settings, LDH becomes elevated because it's an inflammatory byproduct. So if a patient is outpatient with no known infections, then LDH can be a surrogate marker for hemolysis, but in the inpatient setting, it is relatively nonspecific. Haptoglobin depletion tells you that you haptoglobin is a molecule that binds to free hemoglobin to help take it out of the blood. Um, and so you're looking for levels of haptoglobin below normal levels, which tells you that you are depleting it as a result of free hemoglobin being in the blood. But the problem with that is that it doesn't tell you how much hemolysis has occurred. So if you've completely depleted your haptoglobin reserves, then you really don't have any clue as to how bad the hemolysis is, other than it's more than the haptoglobin system can handle. Uh, Hemoglobinuria is another clinical marker where you're seeing red or tea-colored urine. It's easy to see when patients have Foley's, but it sometimes is confused with hematuria, which is the presence of RBCs in the urine. Um, and hemoglobinuria can also occur in cases of general glomerulonephritis or acute tubular necrosis from hypoxic or septic injury to the kidneys. So again, it can be a late signal of hemolysis, but it also can be nonspecific to an injury state. And then finally, bilirubin levels are another one that a lot of people will look at. The higher the bilirubin level, the higher that the hemolysis would have been or was, because bilirubin is a marker of the process of the liver clearing free hemoglobin from patients. It also occurs during acute anemias. So any sort of red cell turnover can drive up bilirubin levels. It is a standardized lab assay that everyone's lab should have. But again, it's not an actual free hemoglobin level. And if you have a patient that is in liver dysfunction, then the liver can't deal with the bilirubin levels. And so the bilirubin tends to climb and climb, even though their source of hemolysis might have been an acute or low level type of hemolysis. So I wanted to sort of now talk about the way that we've applied hemolysis detection for our cell salvage QC process within our hospital. And so if you actually go look at the AABB, or the CAP standards for intraoperative cell salvage quality control programs, they give you this vague, non-specific languages towards the frequency of testing. So they don't really tell you how often you should be testing your systems. And there is some consensus around the stating that the hematocrit of a salvaged blood product is greater than 50%. But quality of wash or the analytes that you assay in your returned product are open for interpretation. So neither the AABB or CAP tell you what exactly you should be assaying for within your cell salvaged return product. The UK Cell Salvage Action Group does spell out frequency of monitoring. UK group does recommend monthly or after servicing of a machine within a hospital setting. The UK system does mention free hemoglobin as one of the tests for wash efficiency, and it states that the clearance of anything that you're analyzing should be within the parameters set by the manufacturer. So we basically took an approach of combining these two types of uh, guidances to determine that we would look to the FDA's 510(k) applications for the cell salvage device that we're using to see what were they saying to the FDA that this is what our product should be able to clear from its baseline state. And so when you look at the 510(k) application, the machine says that it should have a final hematocrit between 40 and 60%, that the heparin washout should be 95% or better. Free hemoglobin is being washed out at better than 95%, and then a red cell blood recovery between the reservoir and the finished product should be greater than 80%. And so we're basically taking this approach to say that for us to pass our quality control, we're going to have a product that will be tested for hematocrit, albumin, plasma-free hemoglobin, and total protein, because we wanted to include plasma-free hemoglobin as part of it because that's what's in the FDA application, and then we also included some other molecules in there as well, just for completeness of the wash product. And these molecules tend to show up in other quality control papers that have been written about cell salvage. And then as part of this testing, we actually test the blood coming out of the reservoir into the cell salvage machine, as well as the blood that is going back towards the patient. And we submit this form to our lab along with the cell saver's ID number. And so the lab will tell us what the reservoir and packed red cell crit, free hemoglobin, protein, potassium, and albumin, as well as we'll provide them with the volumes of the reservoir and the packed red cell content from which the samples were drawn. And then we use all that information to calculate this basically elimination rate of each of the analytes. So elimination rate takes into account the volume of the product as well as the hematocrit of the product in a ratio, so that you can then calculate how much of that analyte that you've cleared in the washing process. So if we take an example of a reservoir sample with a shed blood coming from the field with a crit of 25%, that was in a 1200 ml portion of the reservoir, and with potassium of 4.5. And then we test our post-return product, which has a crit of 65%, a volume of 80 mLs, and a potassium of 2, then you can come up with the fact that the potassium was cleared at a rate of 98.6%, which is greater than 95% and then would have passed for that analyte. And so we've developed basically an easy Excel spreadsheet where we basically put in which cell salvage unit we have, and it automatically populates its serial number. And then we can fill out the values from each of the components from the lab test, and then it'll then run the calculation for each of the analytes that's being tested, along with the packed red cell hematocrit. And these cells are queued so that if the value is below 90%, then it'll turn the cell red. So in this example, we did have a unit that was not clearing the free hemoglobin at the rate that we wanted it to clear it. So we then submitted it for preventative maintenance outside of its normal PM cycle. The company came in, adjusted the cameras, we retested it, and then it passed on the subsequent patient. So what I wanted to say is that, quality control testing for cell salvage is not really an onerous process at all. We basically just draw these samples during the normal processing of our orthopedic or cardiac cell saver blood, and then just submit the samples to the lab. We get a sheet back. We can run the calculations and determine whether the system is operating within its normal expected parameters. You can do this monthly or quarterly. Again, it will depend on whether how you've written your hospital QC policies. And like I said, we've sent 2 of our systems for realignment of cameras in the last 4 years because we've gotten, clearances that have been out of the expected rates. And so that means that, there's something wrong with the way the system's operating. We can pull it from service and get it fixed in a timely manner. One of the reasons that we also pushed for doing a HemoCue based system was we wanted the lab to not complain about having to batch samples for the rest of the lab or the rest of the hospital, but also we can utilize the results from this testing for other purposes. So now that we have hemolysis testing within the hospital, we can use it for any number of other applications within the hospital. Basically as an LDA under CLIA guidelines, but the lab's not going to complain and throw a big fit about it. So with that, I'll close. And if there's questions, we're happy to be happy to answer them.
All right, perfect. Thank you, Tim. That was a really informative talk. I can see we have a couple of questions coming in. Just as a quick reminder to everyone, if you do have additional questions, just drop them into the Q&A box and we can take them from there. So the first one I'm seeing, you mentioned if plasma-free hemoglobin is considered the gold standard for hemolysis assessment, why are indirect methods still being used so frequently?
This has a lot to do with the lab. So if the lab doesn't want to go through the process of doing the necessary paperwork testing for CLIA guidelines for LDAs, um, and deal with either the catechem kit or the um, Dropkin solution, which contains cyanide, which is it's a hazardous material that you have to dispose of in a very particular way. Then they're not gonna bother doing it. And if it is a low volume assay within a laboratory setting, then a lot of labs are either going to outsource it to somebody else that does have the direct methods, and then that's going to take your turnaround time to days, um, or they just would rather rely on lab tests that they already have in their system. So uh, it's a common question that I faced in two different hospital systems where we wanted to get you know more real time or more stat hemolysis values coming from our lab, and so we've sort of pushed back against that notion that you can just be a send out, and trying to get a system in place that is easy to manage from a laboratory standpoint and gives you the results that you're looking for.
All right, thank you for that. The next one I'm seeing, I'm curious about whether the cardioplegia delivery method itself plays a meaningful role in hemolysis, particularly when comparing roller pump delivery and lower volume approaches. Is there evidence suggesting that minimizing mechanical compression and reducing cardioplegia volume can meaningfully reduce red cell trauma during bypass?
With any roller pump, if your occlusions aren't set properly, you will cause red cell damage because of the compression of the walls against each other, and so the red cells that are trapped in between them can be lysed. But the biggest sources for hemolysis within any cardiopulmonary bypass system is going to be your suckers from the field and your vacuum drainage. So, which is the same thing we see with cell salvage in if you use a cell saver as part of your sort of shed blood process within cardiac surgery, or we use cell saver for every spine and hip case in our hospital. If you turn the vacuum up on any of those as well, like you're going to cause a lot more hemolysis. The ortho guys love their ultrasound scalpel systems, which also the more that they use it, the more osteotomies that they're doing, the darker the bag of the waste bag is because there's so much hemolysis in it. And you can see it in the analysis of the shed blood, where you can see free hemoglobin levels of the shed blood coming back to us at like 3,000 milligrams per deciliter. You're going to clear it at 95%, but when you concentrate it to the levels that our cell saver system can do, which is roughly 70-ish%, you'll still see an actual free hemoglobin level of like 1,000 milligrams per deciliter, which seems really high. But again, when you go back to your clearance equations and realizing that you're assaying a very small volume of supernatant, that's why it looks like the values are higher.
All right, the next question. Can we discuss the optimal wash solution? Many pediatric centers use plasmolite instead of normal saline for a better product for our neonates.
Yeah, that's one that we've done as well. So we've switched to utilizing plasmolite. More is just a generalized, it's a better buffered washing solution, in our opinion. And there's been a few papers that have sort of shown that the bicarbonate and the pH and everything of the wash product is more close to what you would want to give back to a small patient. Because again, in cardiac surgery, we're dumping the whole cardiopulmonary bypass system over into the cell saver at the end of the case, which can generate upwards of 200-300 mLs of blood to be able to give back to a 5 kilo patient. So you're if you've got a patient that's bleeding and that's what you're using to help mitigate the loss of red cells, you'd want that solution to be as well buffered as possible, because it's going to be a larger volume for relative to that patient size. So that's why we've sort of gravitated towards plasmolite. As far as hemolysis goes, I don't think that the solution itself matters all that much. It's just more of like the stability of the end product.
All right. The next question, how are you able to successfully introduce this technology to the lab, so plasma-free hemoglobin testing, understanding that potentially the lab will be hesitant to take on another analyzer?
So I've done this twice. The first time I did this was back in UPMC Children's in Pittsburgh, and they were using the catechem kits, and um, they were we were only getting basically, if you did not submit your hemolysis samples by noon that day, then you were not getting a result for the rest of the day. Um, and that was because they needed to batch all of their quality controls and calibration systems. And so when we presented them with, not only do we want to do cell saver QCs, and the ortho cases that we were doing them on were running past, 1 or 2 o'clock. We wanted to know whether, do we need to pull the system out of care of use for the next day? We needed results that were, semi real time, or at least, in a reasonable, 2 hour time frame. Um, and then for all the other aspects of free hemoglobin testing that we wanted, we didn't want to have to wait till the next day. Um, and then my current facility, when I came here to Nemours in Orlando, there was no cardiac surgery program. So we started everything from scratch. And the lab had no free hemoglobin testing at all. So when we explored what the options were, um, it was kind of an easier sell for me to tell them like, hey, we need it in-house. There's a device that's relatively point of care, almost no maintenance, really easy to do the QCs. You can get results really quickly, and there's um, no hazardous cleanup, no easy QC process. So it was kind of an easier sell to our lab in the new hospital relative to trying to get them to switch away from an older assay system.
All right. The next one, when doing QCs quarterly, are you testing all devices and staff?
Uh, so we are testing all devices. We don't necessarily test staff because we the quality the QC process, at least the way we're using it, is primarily directed at the cell saver device itself. So is it performing under nominal conditions that the manufacturer says that it should be operating under? Um, you technically do, in a sense, like test some staff. It's because different staff members are handling the cell saver that day, but it's not tested as like by surgeon or by other provider. Because we run a pretty standardized cell salvage program where the vacuum in the for the wands is set no higher than 100 to 105 millimeters of mercury. The wash modes are fixed. There's no changing of the wash modes for these cases. Again, they're elective. We're not running emergency cell salvage in these systems. So there's really very little interoperator variability. It's more just for the machine's quality.
Okay. The next question is about other analytes in QC. So if you're using the HemoCue to provide plasma-free hemoglobin results, where or from what device are you getting the other values, such as total protein, albumin, etc.?
So those are coming from our lab's standard testing platforms. Off the top of my head, I don't know which machine that they're using to do the total protein or the albumin testing, but we basically just chose from a menu of available laboratory tests that we wanted to look at. Um, so I think most of our lab is running Siemens equipment, and so that's part of like the general like CMP and stat chemistries that they run for all of our ICU patients. So I know potassium, calcium, uh, bilirubin's in there, the albumin, the total protein, like that's all part of the standard sort of chemistry suite that's available with their Siemens equipment.
Okay. The next one is a follow-up on bypass. Do you have recommendations, or what can we do on CPB to decrease plasma-free hemoglobin?
That's an entire webinar that can be dedicated to it because there's a lot of research out there that you know that has tried to do some of this stuff. Anything from you know regulating the vacuum to lower levels to reducing sucker bypass needs to soft shell reservoirs versus hard shell reservoirs, trying to limit at that air blood interface. There's drugs like pentoxifylline that people have talked about using. There's the debates on cannula sizes and trying to push cannulas for different patients. So, um, you know, I will say that like when I do our cases, like you know, the the higher the suckers are ripping, the worse the hemolysis is going to be. So we do try to like limit the amount of sucker bypass and how fast we're running the suckers on our patients. Um, and we keep our vacuums, no higher than -40 for um, all of our cases, and we really try not to push our arterial cannulas past 100 millimeters of mercury of pressure drop. Um, but cardiac surgery is kind of hard because you have heterogeneous patient populations, different hematocrits that can play a role. How much bank blood you're using in a case can uh, play a role in that. How old the bank blood you were using. So there's so many factors you kind of have to control for, and it's really difficult to do those kinds of studies.
All right, it sounds like this next question is
Yep.
good step. Uh, Question is the surgeons at my hospital really push for smaller arterial cannulas, resulting in higher line pressures. To your knowledge, what's the high positive pressure that can result in hemolysis?
So the number that's quoted from some very early studies from like the 60s was actually done for shear stress. And it was 120 dynes per centimeter squared. That is the shear stress out of an arterial cannula that has a significant impact on hemolysis. And so if you take that shear stress and you back it off towards, using just the Huygens-Poiseuille equation to try to figure out what sort of flow rate and then would that occur at in a particular cannula, and then you back that off to the pressure flow curves for the manufacturers and the water test, then that's where we've settled around that 100 to 120 millimeters of mercury as sort of our upper threshold for saying like we really should not be using this cannula for these patients beyond this flow rate. But we still end up with some cases where the aorta is just super small, and so like yes, we want to give them a 10 or a 12, and they're like I can't fit anything bigger than an 8 in here. So um, we live with a line pressure of 350 for the whole case, and slowly watch the urine turn pink.
All right. The next question, have you ever noticed a correlation between the choice of tubing for roller pump? There's a feeling that 1/4 inch by 3/32 causes more significant damage to erythrocytes and induces hemolysis compared to 1/4 inch by 1/16.
I haven't seen any papers related to that. Putting on like my just engineering hat for that. The second number 330 seconds or 1/16, those are wall thicknesses. So all that is telling you is just uh how thick the wall is. The diameter is still the same. It's 1/4 inch for both of these. So for that, what would potentially happen if you're flipping back and forth between 330 seconds and quarter and 1/16 wall thicknesses, your occlusion in the system is probably going to be off because the rollers are basically going to have to push farther on a 1/16 wall thickness than they would on a 332nd. So we do check our occlusions for every case. We use rollers for every case for the arterial pump. All the way from 1/4 inch tubing, 3/16 inch tubing, all the way through 1/2 inch boot for the biggest patients. So we do check our roller occlusions like every single case meticulously, and really try to take care that we're seeing a good, 60 millimeter mercury pressure drop over 40 seconds or so that we know that we're not over occluded and causing hemolysis from the main arterial roller pump. Um, like I said, most of the time, I think that most of our hemolysis comes from the suckers and the speed with which we have to run the suckers to collect the blood from the surgical field.
Next one. Has the shear stress curve ever been applied to HLM occlusions? Since occlusions can be very subjective and can change between HLMs, is there a way to use this curve to optimize our occlusions?
Yeah, so well, so the occlusions for the HLMs are not necessarily like it's more of a crushing stress because that's what the rollers are doing. Um, versus the Leverett curve, which is more for uh, shear stress in terms of like uh, tubing, pump turbines, that kind of stuff. Um, and to me, the most powerful feature of the lever curve is the time and stress and shear stress, axes, right? So um, sometimes we think that we're really protected in some instances when we have like a low shear environment for our devices, but a low shear environment for a very long time uh, is just as detrimental to cells as a very high shear stress, but for a very short amount of time. So, and I think that that debate has come up a lot in the recent use of different centrifugal technologies, and we're starting to realize, sort of, pay more attention to that aspect of those curves. Is that low shear, but for blood that's stuck in those environments for a longer period of time is just as bad as very fast spinning blades or very sort of high stress environments, but for short periods of time.
All right. So I think this topic was touched on, but if there is anything to add to it, beyond minimizing suction-related trauma, are there delivery or perfusion techniques that you found helpful in preserving red cell integrity during bypass?
Um, we do wash all of our blood before we use it. So we try to get rid of, the life cells that from the banked blood. But the secondary reason that we also wash all of our blood before we use it in bypass is that we only use irradiated blood in our institution because we don't necessarily always know when patients have to George or not. So that blood that's been irradiated, the K is over 15. And so if the K is over 15, then you know that there's hemolysis in there too. So that's why we wash it before we use it for every case. So that I think tends to cut down on it a little bit. But I would love to see some more work done with some of these old drugs like petoxyphylline given to patients during bypass that might mitigate sort of shear stress induced, makes them, because pentoxyphylline as a drug tends to make the red cells a little bit more like fluid. They're a little less stiff. The downside of it is that it, makes it easier for the blood to move through capillaries. So when you have open capillaries because you've had surgical incisions, then the bleeding risk, tends to go up. So you're gonna have that balance. You're gonna have to fight between like, making cells easier to get through capillaries, and then, surgeons complaining that there's too much bleeding as a result.
All right. Uh, I think we're coming up on the final few questions here. The next one, any other reason or ideas that their cell salvage is getting clotted, so many of the cases in post-bypass after protamine is completed?
Oh yeah. So this happens a lot. And when you read cell saver, IFUs, they specifically say no prothrombotic materials in the salvage, in the field. Um, and so as much as you can tell your surgeons that, I can guarantee you that they're using gel foam thrombin in the surgical field, and they're using the cell saver sucker to place that gel foam thrombin and suck it down to the place that they're trying to get the bleeding from, and that's just going to cause it to start clotting. You also have them giving factor 7 and everything else to try to control the bleeding, and because again, like that, the bleeding is in the surgical field, so they're sucking that all that stuff up back up to the cell saver system. They've just given more platelets. They're giving cryo, all that stuff. So you basically have a nice prothrombogenic material that's even after you give your protamine, that's causing the cell saver systems to sort of um, become more prothrombogenic. When you have heparin in your cell saver, um, fluids that's running down with the suction tubing. So, sometimes when we start to see like um, the tubing start to get red all the way through because there's cells and materials sticking to it. We basically just turn up the rate on the heparinized saline or heparinized plasma-like solution for the cell saver wand, and just try to wash it all back, and then give the cells that are sitting in the reservoir like a better heparinized, reservoir environment to sit in, so that they might not clot so much once they get through the sock.
All right.
Uh, do I
Perfect.
see free hemoglobin on longer pumpkins? Absolutely. And again, it's the length of time on, using, uh, suckers. Longer pump runs tend to be, patients that have more suture lines, more bleeding, more difficult, surgical repairs. So you're in that environment of, just deranged, um, uh, you know, inflammatory states, high shear stresses from the pumps, from the oxygenators, from the cannula, the suckers, the air blood interface. All of that starts to just come together. And the longer that you're in those situations, the more bank blood you've probably used, because it's a longer case. Then, the more fragile the blood is, the more likely you are to see hemolysis, as a result of it.
All right. So the Q&A has slowed down. I think we can wrap up here. Dr. Maul, I just want to say thank you again for sharing your experience and expertise going through the Q&A with everyone. To the audience, if we didn't get to your specific questions today, please feel free to reach out to your local HemoCue rep. Tim, would you mind clicking? Okay. Um, Additionally, you can scan the QR code that's shown on your screen right now if you're interested in learning more about HemoCue's hemolysis solutions, or to reach out to our team. I'll also be following up after the webinar to share some resources, and you can reach out to me directly there as well. I also want to note quickly that next month we're excited to join AmSECT's International Conference in Austin, so hopefully we'll have a chance to meet and connect with some of you in person there. And finally, just want to say again how much I appreciate everyone taking the time to join us today. One more thank you to AmSECT for partnering with us on this, and to Dr. Maul for the excellent talk. Have a great day, everyone.